Okay. Okay, let me get to my webpage here. Get this thing out of the way. Okay, so this is a quick announcement. I've got to make some changes to the webpage because I'm thinking about the upcoming exam 2, which is, oh goodness, it's just before spring break. Anyway, so the 11th. So it says here, chapter 4, parts 2 and 3. Well, part 2 is the central nervous system, and there's quite a bit of vocab in there. It's not really pathways, so that's good. Chapter 3, I'm going to clarify this, okay? Because what I told you, and I'm going to keep with that, is that for the next lecture quiz down here, okay? So I added this. Everything after acetylcholine signaling, the drugs like dobutamine, atenolol, propranolol, all those drugs, okay? Then the neurotransmitters, dopamine, serotonin, and all of epinephrine signaling, okay? So remember, it's a 50-point quiz. So I'm going to ask more questions than I did for the first quiz. So it's 50, I might have 25 questions, all right? So that's going to be a pretty big quiz. So I'm going to leave that stuff off of this next exam. So what I'm going to do is we're finishing endocrine system, or we will soon be finishing endocrine system. And then we're moving on to muscle physiology. And I'll see how much muscle physiology we get through as that exam date approaches. I think we'll be able to get through all of it. So I'm going to cut the 3 here and then just have 14, and then chapter 6 would be muscle physiology. But I've got to update that on my webpage. I haven't done that yet, but I'm going to do that. All right, because I want to make sure you know what it is you are studying for. And hopefully, get rid of this, you're studying already. I mean, you should be studying the central nervous system. Notice how, now that we're all done with lab, notice how I had a bonus question that was a question on the central nervous system. I have these bonus questions on our quizzes to reward those students that are studying ahead in lecture, which is my way of saying you should be studying ahead in lecture, because if the exam is the 11th, let me move this thing, I have to move this all around. Okay, that means it's here. All right, so you've got this week and then that week to study central nervous system, endocrine system, and then we're going to get into muscle physiology. So be studying now. I would have been studying here for the central nervous system. That's kind of what it takes. All right. Any questions on that? All right. I always try and give you a good heads up before we actually have a test. Okay. People have asked me. I'm going to fill these in. People have asked me. Oh, yes, go ahead.
I just want to let you know your lab 7 on your webpage isn't working.
Which lab is that?
The blood pressure regulation.
I'll check it. Thank you. Could you send me an email after class as a reminder?
Yes.
Because I got a lot of back-to-back appointments until I get back to my office and I'll forget. Thank you. All right, people have asked me how you study for this stuff. Obviously, the flow diagrams help when we have pathways because it's involving pathways a lot of times. But repetitive study. Know how in class I go over stuff and over and over with you? Because that's repetition, and repetition puts things in long-term memory. You should be studying that way. So in my PowerPoints where I have a review slide, basically all the material up to a review slide, that's a good chunk of material to sit down and study for an hour. And then later that day, come back, review what you'd studied and see what you remembered and what you don't. And then add a new chunk of material to study. The next day, review what you studied and make a mark to look over things you still haven't gotten down. Then add a new chunk, like up to these review slides. And then later that day, review. So as you're getting closer to a quiz or an exam, you don't have more than one chunk of new material to study, and most of it all is review at this point. That repetitious study is the way you do it. If you cram a chapter or two the day before an exam, you're not, unless you're especially gifted with a photographic memory, it's not going to work. It really doesn't. I know, I was a student, so I know. But anyway, that's what I would do. Okay, and if any of you are having trouble and want to sit down and talk about the way you're studying, email me. We'll set up a meeting time where we can talk in lab when we've got a break, because we often do. But yeah, talk to me about it. Maybe we can figure it out. Because I want you to succeed. I want you to get this stuff down. And it can be done because there were 2 perfect scores on the last exam. So I know it can be done. Any questions? I know I took up a little bit of time on that, but I think it's important, right? Because this is different from microbiology or anatomy. It's not just rote memorization, it's pathways and application. And that's like nursing. Okay, so I want to encourage you. All right, so we left off with this, but I didn't write anything down. We were talking about adrenal cortex disorders. We covered before this Cushing's, which is excess cortisol. Now we're talking about, when we move this, not enough aldosterone. All right, aldosterone causes your kidneys to retain salt. That salt goes back into your bloodstream, and water will follow that salt back into your bloodstream by osmosis. We had a whole lab on that, okay? All right, so, and then you retain water and your blood pressure goes up. And that's what aldosterone is supposed to do. If someone's got low blood pressure, it's supposed to help bring it back up. But if you don't have enough aldosterone, and I'll let you look at the clinical app online, here's what you're going to have. You're not going to be retaining salt. You have low, come on, pen. You have low blood sodium. And I'm just going to use the symbol. It's low because you're peeing out sodium. Okay. Let me explain the next one. Hyperkalemia. We've covered that before in another chapter. That's high blood potassium. Your kidneys are retaining it. Now, sodium and potassium have this weird relationship. Wherever sodium is going, potassium is going in opposite direction. It's like they can't stand each other. Like sodium comes into a cell, potassium leaves. Like I hate sodium. I want to get out of here. It's that way in your body. If you're losing sodium out in your urine, your kidneys will retain it. Now, do you remember the dangers of high blood potassium? Let me lead you in. What happens when there's a lot of potassium channels opening in the heart? What happens to heart rate? It decreases. So when you have high blood potassium, you are at risk of a decreased heart rate. Okay, I'll put here. I don't want that. I want the pen. Can decrease heart rate with all that potassium. So if someone has Addison's as a nurse, you want to be checking their heart rate when they come in. Okay, hypovolemia. Well, if you're peeing out salt, water also will be lost in urine. Water follows salt wherever it goes. So if you pee out salt, guess what goes with the salt? Water. You're peeing out body water. So you're going to be dehydrated. You have low blood volume. All right, you're dehydrated because high urine output. So high urine output of water. You're losing body water. If your blood volume is low, your blood pressure will follow that. So if blood volume drops, blood pressure drops. So if someone has Addison's, you're monitoring the heart rate. You should be asking them how much they're peeing. You should be checking their blood pressure, which you'll be doing anyway as nurses. The anorexia is loss of body weight due to loss of body water. Okay, not loss of fat, it's loss of body water. Anytime someone drops weight really fast, like in a few days or a week's time, that's not likely to be fat. That's going to be loss of body water because it takes longer to lose fat unless you're absolutely starving yourself. Right, so all those things can be problems. That is, oh, here's a problem, aldosterone's too low. There's also another syndrome called Conn's syndrome, where aldosterone's too high. All right, and so you would see the exact opposite of all these things. Okay, so I think that's the next slide. Let's see. Oh, I forgot hypoglycemia. That's low blood glucose. Due to decreased cortisol. Now, what I really want you to, because I don't want to throw every little detail at you. I really want you to know in Addison's, I want you to know the presentation due to low aldosterone. I know cortisol is involved, but I'm not going to test you on that because it's too much. All right. When you go into nursing, you can learn more complex problems with the endocrine system and all the things going on. But just worry about those because those are all effects of the low aldosterone. Okay. So the next one, oh, skin bronzing. I forgot about that. Oh, it did this to me again. It's trying to, and I don't want you to. There we go. Obviously, hyperpigmentation. I don't know the pathway by which this happens. I'll admit ignorance, and I haven't looked it up because I don't feel like it. But for some reason, this condition, this endocrine condition, makes your melanocytes put out more pigment in your skin. I'd have to Google WebMD or something to figure out how is that, how are those connected? I'm not sure. All right, but these are all things you're going to see in a patient. All right. How would you know their blood sodium is low and their blood potassium is high? These are monitored on any routine clinical blood panel. All right. Okay. So Conn syndrome is the exact opposite. It's hyperaldosteronism. Aldosterone too high. Okay, so everything you see in a clinical presentation is the opposite of what you see with Addison's. If you have too much aldosterone, you have too much salt being retained. High blood sodium, that can increase heart rate. They might have tachycardia. Now, they're not going to be retaining potassium. They're going to be peeing that out. So you have low blood potassium. Both of those things can make the heart rate skyrocket, which can be a problem, not something you should be monitoring patients. Now, so high blood sodium because you are retaining, I'll just put salt. If you're retaining salt and it goes back into the bloodstream, what follows salt? Water. So you have increased blood volume due to water retention at the kidneys. I just put water retention. Okay, because you're retaining salt, you're going to retain water. That's why they tell people who have high blood pressure, avoid salt in your diet. Because you have too much salt in your bloodstream, you're going to be retaining water, and then that makes your blood pressure go up. So if your blood volume goes up because you're retaining water, you will have increased blood pressure. Because whatever happens to your blood volume, your blood pressure follows directly. Okay. And here you can have weight gain due to water retention. Let me go back up to hypernatremia. You're retaining salt. So let me add, I don't know if I have anything else. Oh, let me go, I'm going to add one. Urine output decreases. So if you ask someone and you suspect they have this endocrine disorder, their urine output is going to be very important to know. So let's say you've established that this person has Conn syndrome. You'll analyze, have a blood panel run. You'll get this hormone, aldosterone, measured along with sodium, potassium, and other things. Okay. And you see, oh, you have high aldosterone, it's outside the normal range. You have high blood sodium accompanied by low potassium, and your blood pressure is pretty darn high and heart rate's kind of high. What is your urine output like in the last 24 hours? Have you peed much? No, just, I think I peed once and it was just a little bit. That's a concern, all right? When someone is not peeing much, they're not getting rid of wastes from their bloodstream and they're gonna get really sick really soon, okay? All those toxins building up in your blood from not peeing out the toxins that are there, eventually make a person really, really sick if they're not. Urine output's very important to monitor on a patient. This is why a patient who's been in the hospital, who's been through surgery, they will put a urine catch cup that hangs onto the toilet seat so that when someone pees, they pee into it and the nurses can see what their urine output is. And if the urine output isn't at a certain level, they won't discharge that patient. They want to make sure their kidneys are working. I've been in a hospital and the patient, I know this is true because I had to pee in the stupid thing. All right. So that's how important urine output is. All right. Here is an endocrine disorder that I don't think is all that common. Will you see it? Probably, but it won't be like an everyday kind of thing. So pheochromocytoma, long word saying you have excess, the big thing, that the presentation is high epinephrine in the body. These people are on full flight mode 24/7. And yes, that can kill you because you overstrain your body, you overstrain your heart. They're jacked up and the body can't handle that kind of stress long term. If you've ever been extremely stressed, like a panic attack, how about that? If anyone's ever had a panic attack, imagine that. And they usually, it's a whole other central nervous system disorder. They usually last no longer than an hour at most because it's very stressful. This would be like having a panic attack for 24 hours straight or more. So what happens is, well, we know what epinephrine does to the body. So they have full fight flight symptoms. So they have tachycardia, which is high heart rate, higher than normal. And it's persistent. It doesn't go away. That's going to put incredible strain on the heart. The heart can actually give out unless this is treated. You will have high blood pressure. You know what that is. And that's because your heart rate's sky high. You'll be panting. I don't need to define hyperventilation, do I? Everyone knows that's you're panting, right? High blood glucose. When your body is stressed, now cortisol can do this, but epinephrine certainly can. If someone has high epinephrine in their body is sending out all the reserves. You're going to have a lot of glucose spilled into the bloodstream. You're going to have a lot of fats spilled into the bloodstream. So usually this is triglycerides and fatty acids. And those are measured on any routine blood panel. That's how important they are. So the body, since it's stressed, is sending in all the reserves that you have because it anticipates your body's going to need these reserves. And then, of course, like a panic attack. I can't imagine what this would be like, but they're anxious, they're sweaty, they're, fight, flight. It's a terrible feeling. Okay. I can't remember which disorder comes next, but it might be that's it for the adrenal gland disorders. The others before this were adrenal cortex disorders, and this is an adrenal medulla disorder because that's where the epinephrine comes from. Okay, now we're going to finish some other endocrine glands, keeping track of time. All right, thyroid gland. Some very common endocrine disorders are too much thyroid hormone or not enough. But what do the thyroid hormones do? T3, called because it's triiodothyronine, but everyone just calls it T3. And then thyroxine is T4. So I only say T3, T4. They increase the body's metabolism. How fast all those chemical reactions are happening in your body, in your cells. All right. So obviously your thyroid gland is on the front. This is the larynx. I'll just put L. All right. And this is the trachea down here. And that's where that sucker's found. Now, it also regulates blood calcium, keeps it low by secreting calcitonin. So on the back of the trachea, basically, are the parathyroid glands, which are these suckers right here in green. And I'm only going to mention one thing. They oppose what the thyroid gland does with respect to calcium regulation. And just like muscle groups, if they're on opposing sides of a body, they do opposing things. And so the parathyroid gland will increase your blood calcium. All right. And that's all I'm going to say about that, because there's not often a disorder of the parathyroid gland, but there's often a disorder of the thyroid gland. So let's talk about that because you're going to see them. So thyroid gland disorders, there's a clinical app that I'm going to tell you probably all you need to know, but you can look at it if you like on your own. Hyperthyroidism. Hyper means excess, and thyroidism is, well, the thyroid hormones. So on a typical blood panel, you'd see that T3 and T4 are elevated above the normal range. All right. So it can be caused by a thyroid tumor. They're very common, actually. My cousin had one. She had actually cancer on her thyroid. And so she had to have it taken out, but you can take supplements for those things. Now, another thing that can cause hyperthyroidism is your immune system can attack the thyroid receptors. So autoimmune means your immune system's gone haywire and is attacking your normal healthy tissue. And that's called Graves' disease. And you're going to see that because it's fairly common. I saw a commercial on TV about a woman who was taking medication to treat her Graves' disease because it caused an undesirable side effect of her eyes would bulge out of her eye sockets. And so she'd wear sunglasses all the time because she didn't want people staring at her. So it's common enough that I see commercials for medication to treat it. So clinical presentation. Remember, thyroid hormones regulate your body's metabolism. If they're too high in your bloodstream, your metabolism is going to skyrocket. So high metabolism and anxiety, because your metabolism, your furnace is running really hot. You're literally hot, all right? So you're not tolerant to heat. You can't take the heat. You're always fanning yourself or turning the AC up or whatever and sweating. It causes symptoms that might be similar to pheochromocytoma, but it isn't. So their heart rate is high. They have high blood pressure because the heart rate is high. And here's that thing that I saw in the commercial. Increased fluid behind the eyes causes the eyes to bulge out a little bit. And that's called exophthalmos. And it looks like that. Not the best picture, but you could Google better ones. So how would you know? Blood panel looks for thyroid hormones. If they're high, that's a good indication of the condition. And then you have to do the tests for, is it Graves' disease? And that can be done. Now, hypothyroidism, the opposite. Now your metabolism is shut down. So lots of things. It could be there's insufficient thyroid hormones because you don't have enough iodine in your diet. That is not usually a problem in the United States because all of our salt, unless it's sea salt or the pink Himalayan salt or the special salt, most typical salt that you buy off the shelves is iodized. There's iodine in it, okay? In other countries, that might be an issue. It also could be a thyroid tumor. Clinical presentation, the opposite. Low metabolism, depression, your internal metabolism is so low, it's bottomed out. Now, because your furnace is running low, you're cold, all right? So you don't handle the cold very well. Now you're cranking the heat up and you're bundled in clothes, all right? Your skin might be dry. It can show an enlarged thyroid gland, which can be called a goiter. And I'll explain that in a second. And when low thyroid hormones or hypothyroidism happens in children, they get shorter. They don't grow and meet their growth expectations. And that is called cretinism. We don't typically see this in the United States. Just like I said, we don't typically see pituitary dwarfism and acromegaly, gigantism in kids. Because if you have access to good health care and are keeping track of the kids' growth on the door jam and you know what percentile growth they should be in for their age, and if they're not, you get them to the pediatrician. Same thing with cretinism. If they're not meeting their growth milestones, you get them to a pediatrician and try and rule out what's going on. In other countries, and I looked at someone's nursing statement, and they said they were interested in Doctors or Nurses Without Borders. So that person who goes outside the United States to other countries that don't have access to good health care or finances and things, you're going to see stuff like this because they don't have a doctor to run to when the kid's not meeting their growth milestones. So now, hyperthyroidism and hypothyroidism can both cause goiter. That seems counterintuitive. Why would the thyroid gland grow under both these conditions? Well, it's because of two different things happening. Okay, I have another slide, but let's talk about it here. Graves' disease. This disorder, your antibodies attack and stimulate the thyroid receptors. They're acting like a thyroid receptor agonist. Okay, think about the T experiment. It could be an agonist or a blocker. Well, this condition is an agonist to the receptors. It's like dobutamine, which is a beta-1 adrenergic agonist. It causes more of that activity by stimulating the receptors. With the receptors on the thyroid gland being overstimulated, The thyroid gland says, okay, I'll respond. And it can overgrow and cause a goiter. In this condition, hypothyroidism, something else is happening. And I'll explain it on the next slide more. But here's what's happening. Your thyroid gland is not producing enough thyroid hormones for whatever reason. So thyroid hormone in the blood is too low. Negative feedback dictates that. You have to get that back up. So the hypothalamus is going to release a releasing hormone. Which one is it? It's blank RH. T for thyroid. TRH goes up. What does the pituitary gland increase? TSH. TSH is a hormone that goes down to the thyroid gland and stimulates it, saying, make thyroid hormones. Thyroid gland says, I can't. But it still gets hammered by the hormone and it can overgrow as a result. Now, does that make sense? Okay. Because when I first learned of this, I was like, how can two different conditions, opposing conditions, cause the same symptom? Two different things are happening. Okay. So, sorry about that. Someone's trying to contact me. I'm in class. Shut up. Okay, so normal iodine intake. If you have enough iodine, you need it to make the thyroid hormones. So what happens is the hypothalamus, if it senses that thyroid hormones need to go up, it secretes TRH, and then pituitary releases TSH, and that will stimulate the thyroid gland to make T3 and T4. And as long as it's within normal range, we're good, okay? Now, if you don't have enough iodine, you can't make those hormones. The thyroid gland doesn't have the precursors that it needs to make the hormone. So you have low T3 and T4, hypothalamus sends more TRH, more. Pituitary secretes more TSH. Thyroid gland overgrows. Goiter, okay? So outside of the United States, low iodine can cause this condition, okay? Tumors or in cancers of the thyroid gland can lead to this low T3 and T4, all right? And that can cause a goiter. So hopefully that explains to you how a goiter can happen. In this case, the hormone TSH is overstimulating the thyroid gland in a case of hypothyroidism. In Graves' disease, you have plenty of those hormones. Your body should be shutting it down, but your immune system is throwing antibodies at your thyroid gland that's overstimulating it. And that's why it can grow. Even though your gland can produce the hormones, the receptors are being hammered by those antibodies. So that's what's going on. Imagine trying to explain what I just explained to you to a patient, right? It takes a little bit of understanding of the pathway. Okay, getting to my jam, reproductive physiologist. So your gonads and ovaries produce hormones, all right? The pituitary gland can release LH and FSH. You answer it for me because we've talked about it. What does the testes produce in response to the LH? Testosterone. LH causes the gonads to produce their sex hormones. What does FSH cause to happen in the testes? Sperm maturation. I just put sperm mature. Now in the ovaries, two things are happening. It'll produce sex hormone, which is, estrogen. And it causes another event to happen, ovulation. Now FSH will cause what to happen? Egg maturation. Egg matures usually from, I'll just put that. I'll get to it when I get to the reproductive chapter. But what I've got here is basically that process of happening. An immature egg goes through different stages of development to where it's mature. That's FSH. And then in the body, you get a surge of LH at mid-cycle, and then you get ovulation. So that's what happens. Okay. Now, I need my phone because I need to know what time it is. All right, we're good. Pineal gland. That's all I have on it. It makes melatonin. All right. That helps with your body's night-day cycle. Some people take melatonin because they don't sleep well at night. To my knowledge, I'd have to WebMD it. Yeah, as long as it's not done excessively, it seems to be safe and it does seem to be effective. That's about all I'm going to say because I don't know enough about it, but melatonin somehow regulates your sleep-wake cycle. The pancreas. Do we need to go over that at all? You understand what insulin does, you understand what glucagon does, and what level of blood glucose causes either of those hormones to be secreted because you did a lab report on it. I think we're good. But I do have this. I think it's worth going over. Okay. Diabetes. Glucose is normally completely reabsorbed. So in your kidneys, and I'll get to it much later, your nephrons. In those kidney nephrons, which are what filters our blood, and some things are returned to the bloodstream while other things the body says, nope, it's waste, it's going out in urine. You usually don't see glucose in your urine because it's reabsorbed in the kidney nephrons completely. People with high blood glucose diabetes, they have a problem, either diabetes type 1 or type 2. There is so much glucose in that blood that the kidney nephrons can't reabsorb it. They're simply overwhelmed. And so some of that glucose gets spilled over into the urine, and that's clinically relevant, okay? The unreturned glucose continues along and is excreted in the urine, a condition called glycosuria or glucoseuria, and that is a hallmark of diabetes, okay? So hyperglycemia can lead to your glucose spilling out into the bloodstream, which most of you probably already know because it's one of the big three in the PD. Okay, so back to this. The liver makes a hormone. What can't the liver do? Erythropoeitin. Erythro means red, like as in red blood cell. I'll put RBC because the red blood cells are called erythrocytes. So this hormone makes red blood cell production happen in bone marrow. Okay, the spongy bone of your long bones of your body. All right, that hormone will cause more red blood cells to be produced. Why would this hormone be secreted? Maybe your red blood cells are too low. Maybe you're anemic. A lot of women are anemic because they lose blood every month, okay? Or many other reasons, or if they've had surgery or loss of blood in some fashion. Your liver secretes this hormone to up your blood cell production. It takes about 2 weeks to actually see an increase in red blood cells, all right? Okay. Oh. It responds to a hormone called glucagon. So this is not a hormone the liver makes, but it's responding to that. Again, you know this all too well at this point, so I'm not going to dwell on it. Okay, we are down to the last hormones in the endocrine system that I'm going to cover, your GI tract. So your stomach produces the hormone gastrin. Oop, go back. To stimulate your proton pumps. I'll put proton pumps. And we talked about these. We talked about active transport to make hydrochloric acid, just HCl. Since you took chemistry, do I need to write down that stands for hydrochloric acid, the hydrochloro HCl? So that's stomach acid. So obviously when you start eating, this hormone's being secreted by the stomach because the stomach's saying, oh, got food coming down the line. We got to get the acid going so we can start breaking down the food. Now, I'll put here, GERD. Anyone know what that stands for? Gastroesophageal reflux disease. Equals too much stomach acid can back up into the esophagus. Some people are prone to this. It's often called just reflux disease, it's often called, okay? This is bad. The stomach produces acid, a low acid, pH of 1 point something. It would dissolve anything, okay? How come the stomach doesn't dissolve itself? It produces so much mucus, the mucus coat protects it. But the esophagus does not have that mucus coat. So if acid backs up, either person's producing too much acid, or maybe they have a faulty cardiac sphincter. That's the sphincter that allows food and liquid to get into the stomach. One way or another, acid backs up into the esophagus. Do you think that's going to erode the lining of the esophagus? Yeah. Left untreated, you can actually have erosion, ulceration of the esophagus, which is painful. And then left untreated, you can actually have a perforation, which means a hole, in the esophagus. That means stuff coming down the esophagus can leak into your abdominal cavity, cause major infection. So that's not cool. Has anyone ever heard of Nexium? It's a commonly, Nexium, the purple pill, decreases the proton pump of stomach. It slows them down. I can't fit the whole stomach word in there. It slows down those hydrogen pumps so you don't produce as much hydrochloric acid. So if you have less hydrochloric acid, it's not likely to back up. It also is supposed to help promote healing of the esophagus. I don't know how, but I thought I'd have my own clinical application of this. Okay, next hormone, secretin of the small intestine. It's usually from the first part of the small intestine. Quick anatomy test. Which one's the first part of the small intestine? Duodenum. If you want to say duodenum, I say duodenum. I don't think I have it here. Nope, I don't. It will stimulate secretion of alkaline mucus to counteract the acid. That's important. Acid from the stomach, when the stomach and the pyloric sphincter, which opens up into the duodenum, some acid is going to go with that because the chyme, which is the mixture of acid, food, liquid, whatever, some acid goes along with that into the duodenum. That acid could erode a hole in the duodenum. The duodenum secretes secretin to increase alkaline mucus secretions to basically neutralize the acid, so that doesn't happen. So that's very important. It also stimulates pancreatic enzyme secretion. Okay, so the duodenum is telling, okay, pancreas, I just received some, not dissolved, but broken down food and liquid. I need you to secrete your digestive enzymes so we can start breakdown process, because nutrient absorption begins in the duodenum. And so you got to break down that stuff that's entering the duodenum even more. Okay, good. I didn't overwrite it. The duodenum, when I say small intestine, also secretes cholecystokinin. The chole is going to be important. It stimulates the gallbladder to release bile. I'll put here, bile is made from cholesterol salts. Okay, so your gallbladder stores bile, and when you consume food, your gallbladder will contract with this hormonal signal from the duodenum and release that bile into the duodenum. So if there's fats that have been consumed, it will start release bile to break down fat. That's what bile does. Okay, and bile is made from cholesterol salts. Thus the name, and I hope you remember it this way, cholecystokinin. The chole stands for cholesterol. All right. People who have gallstones, guess what the stones are made of? Cholesterol salts. All right. Cholesterol. Okay. I think the last one. Yay, endocrine system. You survived. You made it. Now, again, the duodenum secretes gastric inhibitory. God, I'm having a hard time this morning. Inhibitory peptide. It does exactly what it sounds like. It inhibits the stomach. It slows gastric motility to improve digestion. You don't want to rush that stuff through the stomach. Give it some time. In anatomy, you probably learned the stomach's got 3 muscle layers. And not only does the stomach have the acid to help break down the food that you've eaten, it churns it in there. All right. All those muscles are working to break that stuff up physically, mechanically, in addition to acid. Okay. Well, 10:10. I could start, I think that's the end. I could start the muscle system, but I think I'll wait and I'll do that on Monday because why not, right? Give you an extra 10 minutes, get a snack, get some coffee. All right. I'll see you guys on Monday and we will start the muscle chapter. And I do believe that is up on the syllabus.